Hey all, welcome to your pain lecture. The lecture today will come in 3 to 4 videos. This first video is an overview of pain and how to assess pain. So what is pain? Pain can be described many different ways, but uh, there are a few things as nurses we need to know regarding pain. First and foremost, whatever the client says the pain is, it is whatever they say. It's a personal experience that has many influences. And know the difference between pain and nociception. I think I said that right. Nociception. And know that pain is learned through life experiences, serves as an adaptive role, and can be expressed in many ways, not just verbally or non verbally. So think about it. As nurses, we are responsible for assessing pain and not making a judgment call as to what a patient's pain is. The influences may include biological aspects, psychological, or social factors. Pain is too complex to have an exact definition. However, you will see it defined in both of the nursing texts we use as an unpleasant sensory and emotional experience associated with or resembling the associated with actual or potential tissue damage. Nociceptive pain is pain from the normal process that results in nauseous stimuli being perceived as painful. Throughout this lecture, you will see how pain it can be different. It can be expressed differently. We will also see that certain people will express pain some way, and then another person will express pain another way. The portion that's adaptive is think of us touching a hot stove. If we did not feel that pain, we wouldn't remove it from that hot stove. So it's adaptive as it protects us from injury. And again, pain can be expressed many different ways, including verbally and non-verbally. However, there are also different body languages that we can see, different things that we can tell if a patient is in pain. You need to know and understand what the gate control theory of pain is. So this theory describes the transmission of pain stimuli and recognizes a relationship between pain and emotions. It figures that small and large diameter nerve fibers conduct and inhibit pain stimuli towards the brain. The gating mechanism determines the impulses that reach the brain. For example, and you'll see this a lot, when you injure yourself, so say you run into a doorknob with your elbow and it hits your funny bone, we know that that can be painful. However, it is common for us when we're injured to rub our arms. Sorry, not rub our arms, but rub the area we have injured to kind of soothe what is happening. And so that actual soothing and friction that we feel is part of that gate control theory. It actually helps less of that painful stimuli reach the brain with the tactile sense of the rubbing. So that gate control theory is basically when we have pain stimuli, we do something that will lessen those stimuli arriving to the brain by a distraction of some sort. Another example of the gate control theory is think of a woman who is going in labor or she's in labor and she's using something to distract her from pain. And I've seen where patients use a comb to distract themselves from pain. So what they do is they squeeze the comb where the pointy part is on the palm, and they squeeze in it enough that that distracts them from labor pains because now the body is trying to process the pain from the comb in the palm. And so that is also a different type of gait control because it's the sharp portion of the comb being squeezed in the palm of the hand, causing less of the labor pain to make it, the labor pain stimuli to make it to the brain, because there is now another set of stimuli going to the brain with that comb. Now, the physiology of pain requires 4 concepts, and those 4 concepts are transduction, transmission, pain perception, and pain modulation. So it starts with transduction, and transduction is that nociceptors become activated by the perception of mechanical, thermal, or chemical stimuli. So the mechanical stimuli are the external forces that result in pressure or friction against the body. They involve stretching of body tissue, such as bleeding or swelling, or compression of tissue caused by the force of trauma, such as being crushed in a car accident, having your leg crushed in a car accident. Thermal stimuli in the transduction phase is that results from extreme heat or cold. So touching a hot stove, or touching really cold ice for a long time, frostbite, any of that. Chemical stimuli can occur internal or external. Think of maybe lemon juice in an open wound, or any acidic substance in a open skin area. Transmission is the conduction of pain messages to the spinal cord. So think of those peripheral nerves that carry the pain messages to the dorsal horn of the spinal cord in a process known as transmission. Pain messages are conducted to the spinal cord along either of the 2 types of fibers. There's either the A delta fiber, which is the large diameter ones that are myelinated, or the C fibers that are smaller and unmyelinated, which are, because they are unmyelinated, it slows the pain impulse. So it might be more of like a dull pain, whereas the A delta fibers are a lot bigger, they're myelinated, and so the pain transmissions go by faster. Pain perception involves the recognition and interpretation of pain in the frontal cortex. The pain threshold is the point at which the brain recognizes and defines the stimulus as pain, the number and intensity of stimuli necessary to produce pain, as well as the duration and characteristics of the pain produced, and they may vary from patient to patient, although the pain threshold usually remains fairly constant for an individual over time. Repeated experiences with pain can reduce a patient's threshold. Think of pain tolerance. That's a patient who's had repeated exposures to pain, and so then the intensity and duration of that pain that they can endure increases. This varies not only from person to person, but also for the same person in different situations. And there are people who can be extremely sensitive to pain, and that's called hyperalgesia. Pain modulation is the process that changes the perception of pain by either facilitating or inhibiting pain signals through the endogenous analgesia system and the gate control mechanism. So the endogenous analgesia system is the system where neurons in the brainstem activate descending nerve fibers that conduct impulses back to the spinal column. These impulses trigger the release of endogenous opioids and other substances to block the continuing pain impulses and provide pain relief. Endogenous opioids are naturally occurring analgesic neurotransmitters such as endorphins. Those usually inhibit the transmission of pain impulses. The other pain modulator is that gate control theory we talked about, where a pain impulse can be modulated at the spinal level. In explaining the mechanism of the pain perception, the gate control theory of pain modulation suggests that the perception of the pain does not occur only by the direct stimulation of the pain-producing fibers or the nociceptors. Instead, pain is perceived by the interplay between two different kinds of fibers, those that produce pain and those that inhibit pain. And you have to know the types of pain, and this is just 2 forms of pain, and there are more kinds, and we will go through those as well. So for these first 2, so acute pain versus chronic pain. Typically, acute pain is a rapid onset. It can vary in intensity from mild to severe and can be protective in nature, so it'll warn us of tissue damage that is occurring or will occur if we don't remove ourselves from that pain. Whereas chronic pain is maladaptive and is recurrent for more than 3 months. And you will see kind of a variation in this chronic pain where it says more than 6 months. Per your Lippincott Fundamentals book, it says more than 3 months. The primary chronic pain, so there, again, chronic pain gets divided into 2 different sources. So there's primary chronic pain, which is the pain itself is considered the disease, such as fibromyalgia or chronic back pain, whereas secondary chronic pain is a result of something such as an illness like cancer or surgery or trauma. You have to know that chronic pain will have periods of remission where there is no pain and exacerbations when that pain comes back. And there's no like set time of when somebody can be in remission and when somebody gets an exacerbation. So because people can have long periods of remission and then have exacerbations. There is no exact set time for it. The other type of pains are localized, which are typically defined to a specific spot or area of the body. So I get a cut in my arm, that pain is localized to that cut. Somatic pain typically originates in the structures of the body and the body's external walls. Visceral pain are those originating from the internal organs, the organs that are found in the thorax, the cranium, or the abdomen. Think of somebody who's having a gallbladder attack or a heart attack. They will have pain because of those organs. Cutaneous pain is superficial pain, usually involving the skin or subcutaneous tissue. Referred pain is pain that originates from somewhere and moves to somewhere else. For example, a person who's having a heart attack might have referred pain of the left arm, or sometimes gas pain after surgery can actually move to the shoulders. So those are what we call referred pain because the pain originates in one place but has moved to a different place. Phantom pain is pain to a limb that is no longer present. So anyone who's had an amputation of some sort, so even an arm amputation, or if they had a mastectomy, they might still feel phantom pains there. Below the knee amputations, above the knee amputations, amputations at the ankle, at the foot, wherever that limb was, or that whatever was amputated, a patient may report pain on that phantom area. And phantom pain is still pain, and we still medicate our patients based on that. Psychogenic pain is pain that comes from a psychological disorder as opposed to a physiological cause. All right, this is a knowledge check. Go ahead and read the question and try to answer it to the best of your ability. All right, so if you answered correctly to the letter C, then you answered that correctly. We want to develop an effective pain management plan because different modalities are used in treatment and management of pain and are often based on how the pain is classified. For example, is it acute versus chronic? Is it localized? Is it cutaneous? So we have to be able to understand the various forms of pain in order to be able to plan our care for our patients. Factors that influence pain can include emotions, past experiences with pain, developmental stage, sociocultural factors, communication skills, and cognitive impairments. So emotions, how does that affect pain or factor the influence of pain? We'll think of the emotion of fear, frustration, anger, and helplessness, and even loneliness. How can that affect pain? It can increase it, definitely with fear and frustration. Think about a patient who recently had a fall and broke their hip. Do you think their fear could affect their mobility because they're afraid of falling, causing more pain? Previous pain experiences. Think about how often patients who have had numerous painful experiences and how anxious they can get about the potential of experiencing pain again. Sometimes past experiences cause patients to be more sensitive to pain. Developmental stages. So, developmental age can definitely affect how a person experiences pain. For example, we know that a child might experience pain completely different than an adult. Think of the behavior people exhibit when they have pain. It is strongly influenced by their stage of development. Social cultural factors. Definitely beliefs about pain and the value of expressing pain or minimizing it is often tied to culture. As you care for clients of various backgrounds, you may notice patterns of behavior. Some patients may gain comfort from crying or moaning when they are in pain, whereas some may value silence and being brave to endure pain. Communication and cognition. We know that some older adults may be unable to report pain because of cognitive impairment. Often their discomfort is evident only in nonverbal cues, such as grimacing, rapid blinking, labored breathing, altered gait, or decreased activity. Although people with dementia might not appear to be experiencing pain, there is no evidence that they have less pain than others. Cognitively impaired adults are no less sensitive to pain, but rather may fail to interpret the sensation as painful. Or they might not be or they may be unable to effectively communicate their pain as others. Although they may not be able to recall their pain, they are nonetheless they can still experience pain. How do our bodies react to pain? So pain can have a huge impact on our body systems. Unrelieved pain can cause changes in the endocrine, cardiovascular, musculoskeletal, respiratory, genital urinary, or gastrointestinal system. How does it affect the endocrine system? So ongoing pain triggers excessive release of the hormones, adrenocorticotropic hormones such as cortisol, antidiuretic hormone, growth hormone, that's a hard word to say, catecholamines, and glucagon. Insulin and testosterone levels decrease. These hormones shift, activate carbohydrate, protein, and fat catabolism, so breakdown, hyperglycemia, and poor glucose use. The inflammatory process combined with these endocrine and metabolic changes can result in weight loss, tachycardia, fever, increased respiratory rate, and even death. Pain affects the cardiovascular system. So unrelieved pain can lead to hypercoagulation, so it can increase clotting and increase the heart rate, blood pressure, cardiac workload, and oxygen demand. The combination of hypercoagulation and increased cardiac workload may lead to unstable angina or chest pain. Intracoronary thrombosis, or clot formations in the vessel that supply the heart, can cause an MI or heart attack. Unrelieved pain affects the musculoskeletal system, can cause impaired muscle formation, fatigue, immobility. Poor controlled pain can prevent the patient from performing activities of daily living and engaging in physical therapy. Respiratory system is affected. So think of a patient in pain. They tend to breathe shallow. This limits thoracic and abdominal movement. Think of somebody who's had surgery when they have to hug a pillow. That's called splinting. Splinting reduces tidal volume, which reduces air exchange in the alveoli, and increase inspiratory and expiratory pressure. These changes can lead to pneumonia or atelectasis. So think about somebody who's had surgery and they are unable to do their deep breathing exercises, which is hugely important post-surgery. Deep breathing exercises prevent pneumonia or a collapsed lung. Genitourinary system. Typically, unrelieved pain causes release of excess amounts of catecholamines, aldosterone, cortisol, angiotensin II, and prostaglandins. These hormones lead to decreased urinary output, urinary retention, can lead to fluid overload, hypertension, and even increased cardiac output. The GI system, in response to pain, intestinal secretions and smooth muscle tone increase, and gastric emptying and motility decreases. And this is hugely important because decreased motility and gastric emptying can actually lead to constipation. And someone who's already in pain and might be taking narcotic medications can actually increase constipation. So we have to take a look at all these factors and how pain and the body's reaction to pain. So how do we assess pain? We assess pain includes obtaining a complete pain history, which includes onset location, what aggravates, what alleviates. We also want to ensure we assess nonverbal signs such as increased blood pressure, pulse, crying, moaning, grimacing. A comprehensive pain assessment includes pain location, quality, intensity, aggravating and alleviating factors, timing, duration, pain relief, and goals for pain relief. And how to treat pain effectively, you must be able to understand the patient's perception of pain. And typically you hear pain as being the fifth vital sign, and understanding that as part of an assessment, you should be assessing pain. A good way to remember how to assess pain, additionally, is the acronym PQRST, which is provocative or palliative pain, the quality and the quantity, the region, is it radiating, severity, timing, treatment, and understanding. So, and this one has the U for understanding. So what we want to know in the PQRST is what's provoking the pain, what relieves it. So what brings the pain on, what makes it better, what makes it worse, what medications are you using currently at the moment, how often are you taking them, do they help, do they cause side effects, have you taken anything else for pain in the past, what was the effect of that, what's the quality, describe the pain, what does it feel like, is it stabbing, burning, sharp, aching, dull, where is it, the region, where is the pain, does it spread everywhere else, does the pain seem to originate somewhere and then move somewhere else. Severity, so how severe is the pain now, is it at its worst, at its least, do you have it most of the time, or is it intermittent, is it constant, and how does this pain affect your life? The timing, when did the pain start? Is it constant? Is it intermittent? How often does it occur? How long does it last? Additionally, you want to ask what pain level are you comfortable with, or is the patient comfortable with? So you want to ask all those other questions, but then you also want to know what pain level is tolerable for them. You know, somebody might say that they're tolerable at a 6, where somebody else might say they can only tolerate a pain level of 1. So we want to assess what is tolerable for the patient, and we also want to educate the patient. You know, we got to tell them if they're less than 24 hours of being post-surgical, are we going to get that pain to 0? Not likely. So we need to educate our patient that that is not possible. But we will try to do as much as possible to get them to a comfortable level. So as part of your pain assessment, you're going to use various forms of pain scales. Here we have 4 different kinds. Visual analog scale, numeric rating scale, which is the most common for an alert and oriented adult, simple descriptor scale, and then Wong-Baker Faces pain rating scale. You do want to know these types of scale, and I will show other types during lecture, but we want you to understand and know what the different types of scales are. So let me pull up one that's a visual analog scale. That one typically it's just typically looks like it'll have numbers and faces all at once, and it might have wording such as no pain, mild annoying pain, nagging pain, distressing, intense, worst pain possible. So let's see. I just want to find a really good one for you here. Let's see. So let me pull that over for you. Okay. So let me just move the camera here. So you can see here that it has a number scale, but it also will have some faces. And then it has no pain, discomforting, distressing, intense, horrible, unimaginable. So this is more visual. Then we have the numeric rating scale. So typically that's a scale from 0 to 10, 0 being no pain at all, 10 being the worst pain possible, and then everything in between that. And then what you have to know is that in a numeric scale, 0 is no pain, 1 to 3 is typically mild pain, 4 to 6 is moderate pain, and then 7 to 10 is severe pain. You need to know these types of, you need to know where the numbers fall, whether it's mild, moderate, or severe, because a lot of the pain medication we administer have the numeric scale and it'll say mild, moderate, or severe, or it'll give you mild 1 through 3, moderate 4 through 6, severe 7 through 10. So we want to know the amount of medication we can give based on that pain scale. The simple descriptor scale is, it's basically linear, it doesn't have any pictures or anything, and it'll just have no pain, mild pain, moderate pain, severe pain, very severe pain, or worst possible pain. It doesn't have faces or numbers attached to it. It's just a simple description of pain. Then there's the Wong-Baker faces pain rating scale. This is a really good scale to use with children because they can point at one of the faces or maybe somebody that's nonverbal. We can assess that someone's crying, grimacing, and making faces that will match with a level 10 of pain. So you want to know the type of pain that the person is describing. So sometimes if they can't communicate, we can use the faces to have the patient select a pain scale. And I'll show you what the Wong-Baker one looks like. Let's see if I can get it in the screen here. Perfect. And as you can see here, it has words attached to it and numbers. So if the person is nonverbal or they can't tell us that they're at a pain of 2, 4, 6, 8, or 10, they can point to a number based on what the face is doing, and that would give us a number. So if your medication has a scale, it should have a parameter, right? Because if it's a PRN medication, we want, a number attached to what we're giving it for. So if the person or patient can't tell us they're at a 10, but we can see that they're crying, they're grimacing, all of that, we can rate them at a 10. Or if they can point and say that's what they're feeling, then we have a number attached to that parameter. And that would work just as well when we're administering medications and assessing pain. And just remember, there are many types of pain scales. These are only 4. And we will see some other ones during lecture, some that may be helpful for patients who have dementia or Alzheimer's. They might have delirium where they can't tell us what type of pain they're having. And we can use different tools to help us assess pain. We also want to know nonverbal signs of pain because sometimes we will assess our patients and they will be unable to tell us what level of pain they're at, or we have to assess and make sure that it's appropriate. So some nonverbal signs of pain, we have facial expressions, right? Grimacing, crying, changes in posture. So if somebody's having severe abdominal pain, they might be clutching their abdomen, the position they might be in. So some patients might find comfort in a knees to chest position because that's the only position that's helping their pain. Slight changes in vital signs, so elevated blood pressure, elevated pulse might indicate that they're having pain. However, this might not change for someone with chronic pain. Somebody that has chronic pain, their blood pressure and pulse may not change at all. So it's important to know that vital sign changes might only show in acute pain episodes. Behavioral manifestations. So like we said, pain can affect the whole body, and even psychologically, patients might show some behavior issues. For example, they might be angry, they might be anxious, they might be teary, they might even get depressed because of the pain and lack of relief of pain. Sometimes we might see somebody that expresses pain and sees it as a weakness. So think of and I think this typically of Hispanic patients. They might not report their pain as being severe because it's a sign of weakness. And again, assessing for depression is important because we might be able to see how much pain is affecting the person's affect. So think of facial expressions, posture, and body positions as reliable indicators of intensity of pain. Basic and common facial expressions that signal pain are wincing, clenching the jaw, closing the eyelids, guarding painful sites. Maintaining a tense position is also a sign of pain. Changes in vital signs generally last only a short time. The body seeks equilibrium, thus, after an hour or so, the vital signs typically return to baseline, even though the patient may still be in pain. Continuous severe pain may elevate vital signs again from time to time, but they rarely remain elevated. Key point is normal vital signs do not mean that the patient is free of pain. Patients may be in pain even if they don't act like they're in pain. So patients who use laughter, distraction, or even sleep to cope with their pain are often undertreated. So key points is to assess pain accurately, you must ask your patients and then believe them. So using an interpreter, if the patient speaks a different language, ask the interpreter to explain to the patient that it is important to manage pain and that you will be using pain scales regularly to assess the patient's pain. Have the interpreter translate and write out explanations and directions for the pain scales so that you can refer to these when you assess your patient. With written directions, patients can point to the face or numeric line to tell them about their pain when no one is present to translate. Some patients may feel that they are being bad or weak if they express pain, such as patients may be withdrawn or stoic. It is important that you establish a trusting relationship with them and convey your concerns and acknowledge the person's pain. If the patient trusts you, he or she will feel free to verbalize thoughts and feelings. This is very important. I've seen patients I saw a patient once walk into the emergency room after they drove themselves while having a heart attack, and they rated their pain at a 3. So it's important to acknowledge and tell the patients that we know they're having pain and that we believe them. Sometimes depression is overlooked when patients are having pain. So it's important to assess for depression when someone is having pain. So as we go through the lecture, I will show you guys how to make a plan of care for different types of pain, specifically acute and chronic pain, as those are priority problems of patients we will care for. So in the next videos, you will see how to create a plan of care for those specific types of patients.